So our biggest barrier in transitioning them back to the community, especially if they're our HIV clients, is getting access to not only medications, but to a doctor that will take them on, to a HIV specialist that will take them on. Housing is huge. So you think, you and I, we know we go home to a warm, secure home. These guys are leaving prison where they had a bed. They had 3 square meals. They didn't have to worry about anything. And now they're going out in these communities. And is there a proper home for them to go and rest their heads at night? If I don't have a house to go lie down in and a place to feel secure, am I going to be worried about taking my HIV meds? I don't think so, right? So housing is huge, to find them a house or a home that they'll feel fine, that they'll be comfortable in and be secure in. The parole board, again, it can be the day that they're being released and we still have no idea where they're going. So then as soon as we get the word, they may be down getting ready to go on the bus to go wherever they're being released to, and we're on the phone trying to find a HIV doctor or a physician to take them on when he reaches that city. So we do release them with a certain amount of meds, a 2-week medication regimen that they can carry with them. But again, if we don't have the housing set up, a doctor for them to see, those things will halt. They may not take their medication because they don't find that that's important right now, that other things may be important, like a house, a bed. So there are a lot of barriers there that we're hoping, with all the people in the room that have been here yesterday and today, can help bridge those gaps that we're finding difficulties getting them out and getting them secure. Because if we don't get them secure, we're setting them up to fail. They're going to come back because they're going to go back to their old ways, right? So if we can set up, a comfortable house, support systems are huge because they've had that in prison. If we can set up those 2 key things, I don't think you'll see them come back through the doors again, because they'll have the support, they'll have their treatments, they'll have those relationships with those people. So I think that's key in order for them to go out into the communities and succeed.
Discharge planning was non-existent, is now improving, but there are a number of problems. First of all, we don't always know where the patient's going. We've been known to book outpatient appointments in hospitals in different cities for the same day, for the same patient, and then cancel the ones that he doesn't need when we find out where he's actually going. There's the support when they get out. The guy may have had a family doc who was looking after him. That family doc doesn't want a patient back who's been in prison, who's a drug addict. They tell him to go somewhere else. If the patient is on morphine for either pain or harm reduction or both, they will have a lot of trouble getting that in the community. And if you don't address the addiction, you cannot address the disease. And so what we find is a big fall-off rate in compliance with medication. At least 50% of people drop off the radar. They don't go to their follow-up appointment. They don't take their medications, and we don't see them again. Nobody sees them again for their HIV until they come back into prison, when they either get their parole revoked or they commit a new crime.
Many times we see a line in the sand that folks who work on, especially the facility side, their work a lot of times by law has to start and stop from when a person enters the gate and when a person exits the gate. And the second the person exits the gate, there really are laws that forbid people from having contact, from funding programs, for being involved. So there's kind of that line in the sand, is that gate, that line at the gate. And literally there are times where there are lines in the street that designate correctional facility property and not. And as soon as you cross that line, it's just, we've developed systems that truly, designate that line in the sand.
There are 13 or 16 ministries involved in health. But if you look at Ministry of Health funds over 800 separate institutions in the province of Ontario for mental health and addiction services. And in our lane, we counted over 22 or 23. And many of these institutions provide a variety of different services. So you can see the complexity. I have my wife is a family physician in town, and she sometimes asks me, well, where do I refer this person? And I say, I don't know. It's just like, it's such a complex system that it's really very difficult to to find the right answer. So what is happening actually for the person who tries to navigate that? It's very difficult to find the right door, and we have the issue of stigma was raised many times today, and I think the stigma is there. Stigma is ubiquitous in our society. Stigma is based on misinformation. But unfortunately, all attempts of educating the society and the members is not translated in diminishing stigma, and unfortunately, there's been large studies and small studies and attempts. It doesn't seem to be changing much. So stigma of mental illness is one. Add to that the stigma of the addiction, if you have the comorbidity. Add to that the stigma of criminalization, and also of some infectious diseases, etc. So you have this very complex issue of stigma and comorbidity, which really affects people's access. What we are good in doing is we have separate services. So in this service, you go to treat your mental issues, and in this service, you go to treat your addiction, and in third service, you go to treat God knows what. But there's no integration at the level of service provision. We leave the integration to the individual. And quite often, actually, the messages we give to that individual are different. Because in one service you hear you don't take meds, in another service you hear you take meds, and the third service you hear only abstinence is the thing. So the most difficult part of the integration of all these messages we leave to the person who is probably least likely to be able to integrate that due to their condition.
The nurses were talking about a care coordinator, a nurse navigator, or designated discharge planner, but someone who would be fluid, going between community and prison, who could help the transition, beat off the trolls, and help see that the plans put in place for a patient in the community are actually executed. For lots of reasons that have been discussed in the last 2 days, inmates hit the community and just don't survive. They come back for what amounts to continuity of care, which is a poor statement about our ability to actually see the plans be executed. And this care coordinator would help attend to comorbidity, which is huge for our patients, especially with HIV, complicates the treatment of HIV, and causes a lot of suffering.
People always like to think of the worst. When you say prisoners, the first thing they think of is your Paul Bernardo or Russell Williams, and they think of inmates as monsters. And what I try and tell people is that they're just people. The vast majority will be released back into our communities. And frankly, from my own personal view, I would prefer to have someone come into prison who's physically, mentally, emotionally well, balanced. And so when I talk to people, I know there's a lot of people that I've not convinced, but that open their minds a lot. Because I say, it's drugs, it's alcohol, it's crimes related to those. So many people are in there for alcohol and drugs, and then committing crimes to support them. So when I try and explain it that way, people are much more open to talking about it. And as a matter of fact, some of my friends have started making donations to our office, which would have never happened before, because they had this perception of, do the time, do the crime, do the time, and all that kind of, bump card poster things, whereas when I actually talk to them and, talk to them about the histories of some of these guys, that in fact a lot of them were victims as children, and that this is not, they didn't just wake up one day and become monsters and start doing things, that there's a context for everything, then I find people are much more open to having discussion and much more empathetic, which is always a nice thing. When I see sort of that light go off in someone's eyes, I think, oh, good, okay, there's somebody else who's getting it. And that's not to say people in prison didn't do things that are terrible, like I'm not, and a lot of them have, but everything has to be seen in a particular context, and that there has to be, if we're going to release them, which we are, we need to make sure that they're successful for everybody's sake, for mine, for theirs, for the offenders. And it's in all of our best interest to have people do well. So when I put it that way, people sort of get it.